Greetings from Key Insights at Lymphoma Myeloma 2016, day number 3. With me is Dr. John Leonard of our lymphoma program at Cornell. John, welcome.
Thank you very much, Maury.
We heard some exciting reports today and talks from various investigators. I was especially impressed with brentuximab vedotin. Where do you think we're ultimately going to find BV, as they call it, in our armamentarium against Hodgkin's disease?
Well, I think clearly brentuximab vedotin is an important drug for patients with relapsed Hodgkin lymphoma, particularly after stem cell transplant, for that relapsed patient population or for selected patients as a consolidation after transplant. So that's pretty much the standard as of today. I think the questions that come up are really going to be moving it earlier in the various lines of therapy. Second line therapy, as you know, is chemotherapy based, and there are a number of different regimens looking at BV either instead of chemotherapy or as part of chemotherapy. Time will tell where that settles down. Obviously, the big study, the big area is in advanced stage Hodgkin's, looking at ABVD versus substitution of ABVD using brentuximab vedotin instead of bleomycin. There is a over 1,000 patient study that has completed accrual, and I think the question is going to be, what is the benefit, if any, of adding brentuximab into that regimen? What's the toxicity? What's the cost? And at the end of the day, how many patients, if there is a benefit, how many patients benefit, and are there patient subsets that would be particularly appropriate to get? So all that's going to come out through the clinical trial, which will, either be definitive one way, definitive the other way, or ambiguous. And I think time will tell. From there, then the question is going to be, well, okay, if you use ABVD for limited stage Hodgkin's now, you substitute brentuximab vedotin in the advanced stage, will we be using it in the limited stage setting? And I think since those patients do even better, it's going to be even harder to identify a subset within the limited stage group that can benefit from the use of BVD there. So it'll be an interesting time to see how all of that plays out.
Yes, there is a little bit of controversy over the role of radiotherapy in limited stage Hodgkin's disease. Yes. Can you foresee perhaps where BV might replace radiotherapy? There seems to be a slight, but very slight, advantage in terms of progression-free survival for the use of radiotherapy in limited stage, but a very small advantage. Do you think that could be obviated by using BV at the end of therapy?
Yeah, I think that's a great question. At the end of the day, more or less in limited stage Hodgkin's, 90% of people are going to be cured with ABVD alone. Radiation may improve the outcome for 5 of those patients with respect to PFS, but not overall survival. So the question will be, again, does BV improve upon radiation, substitute for radiation, have no effect? Or if it does have a benefit, again, you're still left with the equation of treating 9 out of 10 patients that are going to do well. Is there a subset that you can use to predict in the limited stage setting? And unfortunately, in the limited stage setting, the randomized trials are really not in the pipeline at this point to be able to answer that. So I think it's largely going to be speculative or extrapolation from what we see in the advanced stage setting.
We heard in several talks, actually, about the use of BIACOP in more intensive regimens to ABVD. Right. Do you think there's any merit in using these more intensive regimens in terms of their added toxicity, or do you think we should be selective in how we give the more intensive regimens?
Yeah, clearly the data on BIACOP have not really robustly suggested any overall survival difference. It's a similar story as the radiation story, greater progression-free survival, fewer relapses, similar overall survival because the relapsing patients can largely, though not always, be rescued with an auto transplant, and a lot more toxicity. So again, as you know well, the German group has advocated start with BIACOP and then kind of downshift to ABVD, whereas in the U.S. we've more advocated for the start with the ABVD and then upshift if you're not getting a good enough response, if your PET is still positive. That's something that we're doing in limited stage bulky Hodgkin's now, where the PET positive patients in an alliance study are upshifting, so to speak, to more intensive therapy as well as radiation. So I don't think that we're going to see a lot more use of BIACOP or a lot of expansion of use of BIACOP. A, because the benefits are less convincing. B, I think people are very sensitive to toxicity concerns. And C, the new drugs that we have, I think, are more attractive than just dose escalation of chemotherapy, is what we're seeing in BIACOP.
Another one of the hot topics, which is very controversial and very confusing, is double hit and double expressing aggressive lymphomas. What's your take on this? How do you think we should approach these patients as we practice today? What do you do? And what do you think we might want to do in the future?
So diffuse large B-cell lymphoma is turning into kind of a Venn diagram of these different subsets where there's some distinctions and then there's some overlap depending on what markers you're looking at and how you're making the distinction. So looking at diffuse large B-cell lymphoma, one large category, as you know, that we talked about today is primary mediastinal. That's one distinct subset, a minority. I think the consensus, at least in the US, is probably to use our EPOC in the primary mediastinal subgroup. Outside of primary mediastinal, we have two large subsets based on cell of origin. The activated B-cell subtype, often called the non-germinal center subtype, depending on the assay done, and the germinal center subtype. In retrospective studies, the germinal center subtype has been more favorable. However, in prospective studies, that has been called into question a little bit because of some selection biases, and we talked about that today at the meeting. Within the germinal center subset, the more favorable subset, we have a subset called double hit lymphoma, which is based on FISH, usually a BCL2 and MIPI translocations, can also include BCL6 as well. That's a less favorable subset within the more favorable subset, i.e. double hit by FISH tends to be a subset, a small subset of the germinal center large cell lymphomas. On the other hand, the non-germinal center, or ABC subset, overall seems to have a less favorable prognosis than the germinal center. And part of that, the accounting for that less favorable prognosis, is that there is double expression or protein expression, not genetic changes, but protein expression with overexpression of typically MIPI or BCL2. So again, this all comes together like a Venn diagram. And at the end of the day, I think we're a ways from knowing that treatment A versus treatment B is better for one subset or another. As you know, one of the larger studies that's out there that we're waiting on, we'll see some data at ASH this year, is the R-CHOP versus R-EPOC study. And regardless of the primary result of the clinical outcome of that study, one of the key features is that prospectively we are looking at the germinal center, the non-germinal center. We'll be looking at the FISH of these patients, the genetic analyses, other markers. And so ultimately, I think we will at least be able to determine within some of these subsets, if the numbers are high enough, is one treatment, either R-CHOP or R-EPOC, better than the other, and or what is the distinction in outcome? Does this hold up in a prospective fashion? So right now, I think we're choosing between the standard for most large cell lymphomas of R-CHOP and in the double hit by FISH and primary mediastinal. I think there's some more evidence that R-EPOC may be the treatment of choice, but I think for the non-germinal center and the double expressors by protein, we're still sticking with R-CHOP at this point, at least by the data that we have to date.
So while we all certainly agree that the best way to treat the patient is in a clinical trial, what would you say to the practitioner out there, again, just to clarify, for the garden variety large cell lymphoma patient with germinal center, good risk, you would use CHOP-R?
That's right.
What about for large cell lymphoma, ABC or non-germinal center type lymphoma, run-of-the-mill, garden variety, low risk, even though they're ABC? What would you still recommend?
The standard of care would be R-CHOP, and the prospective studies, the control arms on prospective studies, looking at the non-germinal center subtype, prospectively treated with R-CHOP on a clinical trial, is that the progression-free survivals at about 2 years are sitting around 78 to 80%. So still, I think, pretty good.
On double hit and double expressors, what would you do if your patient were not in a clinical trial?
So the double expressors by protein are still typically treated with R-CHOP.
Okay.
And the double hit by FISH, I would say that we know that R-CHOP is not adequate therapy. It's not good therapy for that patient population. Retrospective studies looking at different patients that were selected for treatment in different ways, those patients that were treated with R-EPOCH seemed to do better. So I think even outside of a trial, the double hit, I would typically give R-EPOCH for.
Well, we heard several papers on CAR T and lymphoma today. Where would you think CAR T is ultimately going to end up in terms of our lymphoma armamentarium?
Yeah, Peter Martin gave a great talk on CAR T cells from our group, and he really looked at the evidence in a very objective and kind of critical way based on what's been published, which is of course what we need to be looking at. And one of the challenges is that these are moving targets, or different T cell constructs, or different companies, CAR T cell constructs, different companies. Abstracts get reported or press releases get put out with going from 10 patients to 15 patients. The evaluable patient population changes in that some patients get intended to put on the trial but don't get the treatment because they progress. So the numbers are very hard to interpret, and he did a good job walking through that. I think the main messages of that are that it's a work in progress. CAR T cells, there are some patients, the question is what percent of patients, but there are some patients with very bad lymphomas who seem to do pretty well with CAR T cells, particularly the aggressive subtype. The issue is what percent of patients is that, and how durable is that, and how reflective of that is that of the total population. Recognizing that it's kind of a funnel, that you have lots of patients you see in your practice with refractory lymphoma that are desperate, that need therapies, that might be interested in pursuing, or you may be interested in pursuing for them, a CAR T cell trial. And for every 10 of those patients, the numbers that find their way to a CAR T cell trial, and again, it's not a trial that you're doing in your office that you can say, okay, you've relapsed, let's start you on the study tomorrow and we're ready to go. These are studies that require going to specialized centers, that require, that have eligibility criteria, that require the patient kind of hang in there for several weeks. And in refractory lymphoma, when the overall survival can be 4 months, how many people are dropping out during the month that are there, and are they in the denominator? So it's really that funnel gets narrow, and what you're seeing is kind of the output of the funnel, not everything that went into the funnel as far as the denominator of the patients, the percentage of patients that are helped. That being said, these are therapies that work in a different way, and that in some cases seem to be having a dramatic impact. So I think we need to keep looking at it, but I think people need to hold the data to some high standards with respect to kind of an intention to treat analysis to know really what's the denominator of patients. So a lot of work to do, and there's also, I think, as you heard and as you know, a substantial amount of toxicity. That a patient's going to be in the ICU for a week with a cytokine release syndrome, not recognizing their family, that treatment better work pretty well on the other side to put somebody through that. So I think we have a ways to go there, but nonetheless, as Peter alluded to, a lot of people are working very hard on this, and I'm hopeful that with additional work and fine-tuning and patient selection and tweaking out these regimens better, that the therapeutic index will improve, the time to getting the product will improve, and the percentage of patients that can benefit will increase.
One of the controversial and confusing issues which was addressed at the meeting was mantle cell lymphoma, how to treat it. How do you approach mantle cell lymphoma?
Well, mantle cell lymphoma, and I spoke a bit on mantle cell during the meeting. I think that most people approach mantle cell as what can the patient tolerate. Younger patients tend to get more aggressive therapies because they can tolerate them. Older patients tend to get less aggressive therapies because they can't tolerate the more aggressive therapies. At the end of the day, that's not a very satisfying or probably appropriate way to treat patients. Obviously, you choose between one approach or another based on the benefit to the patient, the advantages to the patient. And the point I tried to at least explore at the meeting is that at the end of the day, the dominant parameter that's going to affect how a patient does with mantle cell lymphoma is their risk profile, their MIPI risk profile, which is dependent on clinical features like age, performance status, LDH, Ki-67, and that regardless of the treatment, the risk profile of the patient is what's going to best predict the outcome, not the treatment that we choose. And when you look across studies with different modalities, it's clear that no matter how you treat a favorable risk patient, they do pretty well, relatively speaking to what we've thought in mantle cell historically, with overall survivals probably double or triple of what they were even 10 years ago. On the other hand, if you have an unfavorable patient, very few of those older, sicker patients make it onto a trial of intensive therapy, and those less favorable prognostic patients are not going to do as well whether you treat them aggressively or not. And so at the end of the day, a big factor, and maybe perhaps a driving factor for many patients, is what is the quality of life of the patient? If they are going to live a similar amount of time, do they prefer a scenario where they might be on a chronic maintenance therapy as part of their treatment? Do they mind having a shorter remission if they have less toxicity up front? Or do they want to go through the rigors of a transplant, recognizing that they may not live longer or might live marginally longer, but they may have a longer remission, and the toxicity of the transplant may or may not be worth that disease-free interval based on the perception of the patient.
Let me give you a specific situation which I'd like to ask you on how you would advise this patient. You have a young, otherwise fit patient who has a high Ki-67 index and has a high MIPI, but he's young and he's fit.
Right.
What would you advise him to do?
Well, that's a patient that I would say can tolerate an aggressive approach, that is less likely to do well based on his MIPI within any treatment parameter group, i.e. if you look at the transplant aggressive studies, he's in a group that's likely to do less well. If you look at the less aggressive studies, he's going to do less well. That is a patient who I think I would be thinking about novel clinical trials and novel agents, because doing a transplant or giving aggressive therapy that's going to work for 2 or 3 years is not particularly satisfying. So I might look for a trial that incorporates something new. But outside of a trial, I probably would be inclined in that patient to treat him more aggressively because of his risk profile, knowing, however, that the data that I'm basing that on is based on a relatively small number of patients in these trials to draw from who have really had high-risk features. Because when you look at the transplant-based trials, you're talking about 20% of the patients in these trials reflecting a patient with a high-risk MIPI. And many of these trials are 50 patients, 100 patients, 200 patients. So you're drawing your conclusions on really a small subset. And in that group, the Nordic regimen is an example. A very aggressive regimen has progression-free and overall survivals that are in the range of 4 to 5 years with respect to PFS, which is inferior than other transplant data with more favorable patients.
But when you say you would be more aggressive, are you willing to include transplant?
Yes, I would in
you
that
would
patient.
In this particular patient.
I would be.
Yeah, since you mentioned the Nordic trial, some of their results and some other results have suggested that Erasee has a role in mantle cell lymphoma.
Right.
Do you employ Erasee in treating your mantle cell patients?
So we have a randomized trial of R-CHOP followed by auto transplant versus R-CHOP alternating with R-DAP followed by auto transplant. So again, the main difference there seems to be the Erasee. And that study shows better rates of MRD negativity. Those studies, the randomized trial, which was presented earlier this year, published earlier this year, suggests better progression-free survival. So while Erasee adds toxicity, so again that figures into the profile, I think if you've got a patient who you've decided to commit to a transplant, who's willing to put up with the toxicity of the transplant, that you feel that there's going to be a benefit in the trade-offs around that, I would go ahead and give them Erasee, because I say if you're going to go the full, part way, you might as well go the full way and give them the Erasee to give them the best chance of having a durable remission as part of their transplant.
Another exciting aspect of the conference today was the emphasis on novel agents or innovative agents, if you will, or targeted agents. Where do you think we will be going with them? We can talk about Revlimid, we can talk about the checkpoint inhibitors and monoclonal antibodies. Where do you think we're going to be going with them, and where do you think they'll be most effectively employed?
Sure. So I think the first area is really novel anti-CD20s. Obinutuzumab, now used in CLL in many different settings. We have some studies that are looking at obinutuzumab, a novel anti-CD20, in follicular lymphoma, in large cell lymphoma, in mantle cell lymphoma. So those studies are coming along, and we'll see if that displaces rituximab in some settings over time. Again, time will tell. When we look at other targeted agents that we had as part of the discussion, lenalidomide has been combined with rituximab. It's been combined with R-CHOP, a number of different novel agents. I think that we'll have some data before long looking at lenalidomide rituximab as part of initial therapy in follicular lymphoma, and whether that, how that compares to chemotherapy plus rituximab, and that will be very interesting to see. We'll see data on rituximab versus lenalidomide rituximab in relapsed follicular lymphoma. So we'll see what's the benefit of adding lenalidomide to rituximab in relapsed FL. We'll see some data with that, with lenalidomide with R-CHOP, particularly in the non-germinal center subtype of large cell lymphoma. So a lot of data with lenalidomide moving forward. I think ibrutinib, we have data moving forward in mantle cell lymphoma, a variety of different combinations. I'm sure you've discussed the CLL data with Rick Furman earlier in your discussions. And I think we'll see data with ibrutinib in the non-germinal center large cell lymphoma, and there are randomized trials going on there. So certainly lenalidomide, ibrutinib, perhaps less so idelalisib, although certainly that is approved in relapsed refractory follicular lymphoma and can still be helpful for some patients, but with close toxicity monitoring. And then I think another big area of interest will be venetoclax. Venetoclax is, as you know, approved as a BCL2 inhibitor in 17p deleted CLL. There are a number of different trials looking at it in a variety of different lymphomas. Again, it seems to be relatively safe in combination with other agents, but again, what's its added value versus the side effect profile will be determined, obviously, in randomized trials ultimately.
Do you think it might have a role in large cell lymphoma where you're seeing overexpression of BCL2 with MIPI? Do you think that might?
Well, it would make a lot of sense to look at it there, particularly in the BCL2 overexpressors, as we discussed briefly in the meeting, in the double hit lymphoma subtype in particular, using R-EPOCH, which seems to be a standard for double hit lymphomas in combination with venetoclax, is something that we're looking at soon. At Cornell and 5 other centers, we're opening the phase 1 trial within the next month or two, and we hope to, through the cooperative groups, look at that in a randomized fashion in the future.
Well, these certainly are exciting times in lymphoma. John, we thank you very much for your observations. This is Morton Coleman, Director of the Center for Lymphoma and Myeloma, wishing you a good day.